Hello, my name is Bob Gerber. I'm an interventional cardiologist from East Sussex, down in Hastings and Eastbourne, and welcome you today to a roundtable discussion here at ACI 2017 with an esteemed panel to talk about one of the topics that is particularly of interest to me and something that I face every day on the South Coast is elderly PCI and the challenges that we have with having to deal with complex lesions, quite often acutely in the middle of the night, and what we can do and what we can learn from the practical aspects and also the literature on how we can manage particularly the octo and nonagenarians. I'd like to introduce to my right Dr. Vijay Kunadian, who's an academic interventional cardiologist in Newcastle University and Freeman Hospital. Welcome.
Thank you very much for having me.
Sitting next to her is Dr. Roby Rakhit, who's an interventional cardiologist in the Royal Free, a senior interventional cardiologist, and was leading a lot on studies, particularly in OCT. And I think his insights into how to deal particularly with some of the lesion subsets would be useful. So Vijay, just turning to yourself initially, we've got an elderly patient, we need to take them on. What is there in the literature that can help us, or is there anything in the literature that can help us? Is it right that we should be taking on patients in their late 80s, or in my view, and it's maybe a slightly old-fashioned approach, would be to not intervene? My gut instinct as an interventionist is yes, we must intervene. Is that right? What's your take on that?
Okay, thank you very much, Bob, for having me, and it certainly is a very, very important topic of discussion, and particularly in the era of us leading, having to handle with patients that are increasingly older. So in terms of when I trained in intervention, I learned PCI in a 50-year-old or 60-year-old, but at the moment, up to 80% of my patients in my list are over 75 or in their 80s and 85. So you scratch your head, what do I do with these patients? You, of course, go ahead and look at the literature, what's available. Unfortunately, there isn't very much in the literature than we would like to have. And it's purely because majority of the studies were designed in younger individuals.
Right.
The mean age is around 62 years of age, which is what our NICE guidelines and the ESC guidelines are based on.
And do you think that might be because of the studies were designed by companies and there was a fear that in older patients you might have more events? And do you think that might be
Absolutely. I think that had a major, probably played a role in terms of inclusion. Only 9% of the trial participants are over 75. Up to 32 to 38% of clinical trials actively excluded over 75-year-old. So they chose a cutoff of more than 75. If you're more than 75, you're not going into the clinical trial. So we don't really have very much evidence. There are some particularly guiding us in the management of non-ST elevation myocardial infarction, for example. How do we deal with it? There are small studies, sample size of 200 or 300 patients, and some of them are registry studies that come from Italy and Germany. In terms of randomized clinical trials, again, this very small, a sub-analysis of big randomized trial where they looked at the cohort of patients over 75 years of age. More recently, there has been a publication in Lancet, presented last year at the American College of Cardiology, I think it was the year before, came from Norway, where, again, very small sample size, patients in the hundreds. They screened thousands of patients and ended up with a very small, I think about 200 in each cohort. And these consist of very highly selective cohorts of patients. And that does not probably relate to the day-to-day patients that we see, for example. So we not only see patients that are older, but we have to handle with patients that have a lot of comorbidities, for example. So our patients got a big list of comorbidities. And in addition, the element of frailty comes along. So your 85-year-old patient might look like a 70-year-old, and his or her outcome is exactly going to be like that.
So in terms of so we're part of the trial, the randomised trial at the moment that's ongoing through Brighton, which is Adam de Belder and Must Technology has been very supportive in this part in terms of the literature, where they're looking at invasive versus medical treatment in the octogenarian. Some of the challenges, Robbie, in this trial that I've faced is that you try and consent patients in their 80s for PCI and they don't want it. And the converse is that you would suggest to patients that they have medical treatment and they want intervention, and therefore they don't agree to go into the study. What's your perception sort of clinically in the patients that you see that are over the age of 80? Do you think on the whole they're mostly get intervention, or?
I think historically it's quite clear to me that clinically we were disenfranchising elderly patients, and we know from registries that actually revascularization in oxygenates in particular has been underrepresented. But I think as our techniques have improved over the years, particularly with changing access site from femoral to radial, we're now able to do intervention in this elderly cohort safely and with good efficacy. I think coming back to the concept of consent, I think is very important, and I think it's very difficult having fully informed consent in this age group, particularly when there may be other comorbidities and also cognitive impairments. So I think we have to be very mindful that we need to do informed consent well.
Can I just focus a little bit on some of the practical aspects as an interventionist? What sort of things would you say you need to either skill up or be mindful of if you're, taking on a patient, particularly say if they're in stable multivessel disease, declined surgery, maybe because of age, a bit of frailty, but they're getting ongoing symptoms, they've got ischemia. What sort of things are you thinking of or are mindful of in particular in this patient group?
I think we have to take a much more holistic approach initially to case selection in this group, and we can't ignore aspects like frailty, comorbidities. We know this group is overrepresented as females, low body weight, anemia and renal disease, and I think we need to be mindful of all those factors.
But when you intervene, what sort of things are you...
Well, we recognise that the pattern of disease is generally complex, diffuse and heavily calcified, and tortuosity can be a significant problem with respect to access. My default would always be to aim for a radial approach. I have a low threshold for changing to left radial to avoid aortosubclavian tortuosity, which can be a real problem in this age group. And actually,
do you find that potentially better if you're struggling to get your guide round the from the brachiocephalic artery into the arch?
Very much
switch
so.
To the
I would switch and in fact, some colleagues of mine would actually use left radial as a default in this age group, knowing that you will have both unfolding of the aorta plus aortosubclavian tortuosity.
Calcification, are you? Do you think that rotablation's acceptable?
I think one needs to be mindful that calcification is going to be a problem. Rotablation, I think, is safe and effective in this population and can be done transradially quite safely. We also have other ablative techniques which can help success with PCI, including cutting balloons and newer developments such as laser and intracorneal lithotripsy would, I think, be game changers in this group. We need to be mindful of pharmacotherapy.
Do you use more drug-eluting stents or bare metal stents, or you just will use a drug-eluting stent that you think you can curtail antiplatelet therapy because of bleeding concerns, or does that not feature?
I think bleeding is a significant concern. What we don't necessarily appreciate is what happens later when the patient is discharged from hospital, and we do see anecdotally bleeding problems several months down the line, which we would not have expected, which could be a problem with a sort of non-contemporary drug-eluting stent. We use a lot of biofreedom stents in the advanced elderly, particularly if there's unexplained anemia, for appreciating risks of bleeding later on. So I think the biofreedom stent has been a very useful adjunct in our use of drug-eluting stents.
So Vijay, coming back to you, in terms of studies, in particular, the study that you're conducting, could you give me a snapshot of that?
Sure, yes. I mean, we designed Seniorito Seniorito is the trial that we're working on, which is funded by the British Heart Foundation, and we have sites all across the UK in the 4 countries to address all of the questions, at least most of the questions that are not addressed in the previously conducted registry studies and the small randomized studies. in particular evaluating the effect of frailty, comorbidity, and as Rohit was referring to, is on the comorbidity indices, cognitive impaired patients.
So it's a randomized trial?
It is a randomized clinical trial. We have the largest sample size, so we're looking to recruit 2,300 patients. So that would be the largest sort of, in terms of well-powered trial to address the questions. So we randomize patients into optimal medical therapy, including the current guideline recommended pharmacotherapy, versus invasive care in addition to the optimal medical therapy. So in the invasive arm, patients will undergo coronary angiography, and the revascularization strategy will be as per the discretion of the treating cardiologist.
And the age cutoff is above 75, is
75,
that right?
And primarily we chose that cutoff because of the reason that every prior studies that has been held use 75 years of age as the cutoff for not including patients. So hence we went with the cutoff age of 75 years of age.
Is there a maximum age cutoff?
There is no maximum age cutoff, no. So they could be 100, they could be 96, they could be 80, they could be 75. So all patients above 75. And it's an open study, type 1 and STEMI. And we're also including patients that are unable to provide informed consent.
Right.
And primarily this is coming from a lot of the stroke studies, for example. The patients' relatives or carers are able to provide the consent. And one of the big exclusion criteria for these patients not getting into studies because they're not able to consent. So we have a ethical approval for utilizing the consent process from the carers and relatives. So it will be a broad, hopefully by the end of the study, we will have a cohort of patients that reflects your everyday practice, my everyday practice, and how do we handle these patients.
And so is it a clinical endpoint trial?
Yes, the primary endpoint of this trial is a composite of occurrence of death and non-fatal myocardial infarction at 1 year. In addition to that, we have a huge set of secondary endpoints. And of course, in the state we are in our NHS, cost becomes the significant sort of factor driving what do we do with these patients. They stay in hospital forever, or is there any point in doing them? So we're doing a big economic evaluation to look at the cost effectiveness of offering invasive care to these patients. So hopefully, again, that has not been addressed in any of the previous studies. And of course, when they become older, quality of life becomes a major element. And we're doing a major quality of life evaluation using the health economics team from Newcastle University. So
great. So lastly, you mentioned stroke, other comorbidities. I just want to get a view from both of you, and start with Robbie, as somebody that previously was a cath lab lead and was part of sort of guideline within the free, and also as a honorary senior lecturer at UCL as well. What's your view on patients, for example, that have had a stroke, they're on an anticoagulant, which we see in the elderly are more likely to be on anticoagulant, or they have atrial fibrillation that's permanent, but they come in as an ACS, or they do require stenting. What do you do in those patients, basically?
Those patients are challenging. Initially, obviously, we would withdraw the anticoagulation in order to hopefully safely perform the PCI, and we utilise the ESC guidelines, which have been drawn from the WORST study, which show the efficacy of clopidogrel as monotherapy in patients who have had coronary intervention, even if it's a drug-eluting stent. So we'd probably for the first 4 weeks perhaps give triple therapy and then step down to monotherapy.
Is there a role for NOACs in these patients? Are you doing that routinely, or is it on a patient-based kind of basis? And
there's no data really to support the use of NOACs together with antiplatelet agents in the context of either stable or acute coronary disease. So I think this is an area which need further exploration. Of course, extrapolating from trials such as Atlas TIMI 51, there clearly is a signal of benefit.
There was recently just at the AHA there was a study that the Pioneer that I did attend that suggested that rivaroxaban might be, a slightly smaller dose with one of the antiplatelets might be the thing to go with, slightly in terms of bleeding over warfarin. And certainly my interest is partly in that, and we presented our audit data at the BCS last year showing that actually NOAC being slightly better than VKA. What's your practice?
So
Vijay?
I do exactly the same as Roby was referring to, in that we follow the ESC guidelines.
Right.
And
I mean, the ESC guidance says you can use NOACs with caution, so it's not out.
Yeah.
But,
Well, they primarily referred to warfarin, but there's also, as you mentioned, the NOACs, and we do need data. And interestingly, I think we are going to have another trial that's been presented in the upcoming meetings.
Just personally, I feel it's quite bad. You know, you've had a heart attack, and I'm making you take warfarin on top of it, which is, as you know, has all the issues.
Yes.
But obviously, that is something that
I think
needs further work.
One of the sort of the clinical paradigms we haven't really cracked is recurrent disease and recurrent events. And we know that there is a prothrombogenic signal in patients who present with acute coronary syndromes. And historically, interestingly, warfarin has been protective against recurrent MI. And I think this is where the paradigm shift is from antiplatelets to augmented antithrombotic medication. So, and we know that the elderly tend to have also recurrent progressive disease. So I think there may well be a role, provided we can balance efficacy versus bleeding.
And are you both happy using newer antiplatelets in the elderly, or do you favour clopidogrel use?
So
not in the context of atrial fibrillation or an anticoagulant, just on its own.
I use the novel, newer antiplatelets because we do have some sub-analysis from the major trials of the newer agent to say that particularly with ticagrelor, comparing less than 75 or over 70 from the sub-analysis from the Plato trial, shows similar efficacy without increase in bleeding.
Robbie?
Well, I believe in Plato over 75s actually did better with respect to outcomes, which was counterintuitive after prasugrel, but there is a clear signal. So that we would definitely use ticagrelor over clopidogrel in acute coronary syndrome. So I don't have any particular concerns. The risks with bradycardia, I rarely see. I have to say, and then bleeding per se related to these agents, we haven't seen any excess bleeding related to clopidogrel in our patients clinically. So.
Right, great. Well, that's it. You've heard it here. How we can deal with PCI in the elderly, and some of the new things that are coming up, particularly the exciting trial, the old Rita, which we're looking forward to, which we're going to participate in. So thank you, Robbie. Thank you, Vijay.
Thank you very much, Bob.
Thank you for the invitation.